All right. Now that we've spent a little bit of time talking about the pharmacokinetics and a little bit about the details of the sort of medicine and opioid addiction itself, we're going to move to some of the more practical elements of discussion today, particularly around induction. And I just want to preface this by saying that we are going to be presenting both sort of a hybrid of best practices and then also how we have chosen to implement Suboxone and Subutex induction in our hospital, which is a local community hospital at the county level with a physician training program attached to it. So let's first of all think through sort of your pre-induction checklist. So what do you want to know before starting somebody on Suboxone or Subutex? First thing that you need to establish, of course, is the patient wants to abstain from opioids. Frequently when we have patients admitted to the hospital who have active opioid use disorders, they're not interested in stopping that at any time soon. And so you want to make sure that they are interested in doing that before you get started. You want to actually consent the patient regarding expectations, risks, benefits of buprenorphine therapy. In particular, you should touch on 2 points, which includes the risk of precipitated withdrawal. Of course, you're going to do everything in your power to avoid that using techniques that we'll talk about, but it is there. And precipitated withdrawal can be quite dangerous and certainly more dangerous than traditional regular withdrawal if they were to go into that on the street. And then I think it's important also to set an expectation for lifelong therapy with this medication. There's been a lot of discussion and debate around whether this medicine is something that should be used for to ease the symptoms of withdrawal and eventually be tapered within a few days or weeks' time, or whether this medication should be used for maintenance therapy over the long run. And we'll talk a little bit about some of the data showing that really lifelong therapy is a better choice for this agent. There is some lab work that you should get done before you start somebody on Suboxone to make sure that that's going to be safe. When you have them admitted to the hospital, it's particularly important to make sure that you have a reason for admitting them to the hospital that is not just Suboxone or Subutex induction. If they really just need admission for Subutex or Suboxone induction, that's something that a licensed treatment facility should be dealing with and not just a traditional hospital. There are other things such as outpatient considerations, and we'll talk about that. It's really important if you're admitting somebody to the hospital, they're going to have good follow-up for this medication. Otherwise, the risk of them relapsing when they leave the hospital is quite high. And then you want to establish that the patient is in withdrawal specifically so that you can avoid precipitated withdrawal for these patients. So who are the right people to select for Suboxone and Subutex? Generally, the answer is pretty broad, but there are a couple of contraindications and then some softer considerations that you should have. So for contraindications, obviously, if somebody has a documented allergy to buprenorphine, it's rare but possible. That's not a good candidate for these medicines. And then for patients who are truly medically unstable, they may not be able to tolerate withdrawal safely, and so it may be something that you need to get them medically optimized before you can start this medicine. Areas to be cautious include patients with severe psychiatric illness. These patients, for some, can have a lot of trouble with daily self-dosing of medicines or being able to keep track of medicines, that type of thing. They may be better served by a clinic that can help them, such as a methadone clinic that will help them with administering doses on a regular basis. If a patient is anticipated to have acute pain or surgery within the next 48 hours, it does make the induction of these medications a little bit more challenging, and so sometimes can be wise to wait a little while to do that. If a patient has a concurrent active alcohol or benzodiazepine use disorder, it's something to consider before you start buprenorphine. And then if a patient has liver disease or elevated liver enzymes that are greater than 5 times the upper limit of normal, buprenorphine does have an effect on the liver, and so we have to be cautious there. Methadone in particular, when you're thinking about precipitated withdrawal, has an extremely long half-life. And so using caution when patients have been on methadone is really important. Many institutions recommend waiting at least 7 days from the last dose of methadone before starting a medicine like Suboxone or Subutex. and other facilities choose a slightly shorter time. Our facility has chosen a 7-day window as a guideline. And then, of course, for patients on seizure and HIV treatment, there are certain medications where there can be additive effects, and so they do require some special monitoring. Labs that you want to get before somebody is started on Suboxone or Subutex include a urine drug screen to monitor for other substances that the patient may be struggling with. You want an alcohol level to assess for that concurrent alcohol use disorder. A comprehensive metabolic panel will get your liver enzymes. And then a beta-HCG is really important for women who are of reproductive age. And of course, that's because you'll be choosing between Suboxone and Subutex based on the results of that test, should the pregnancy be desired. An HIV test to assess whether you have to use caution or if somebody's going to need to start on antiretroviral agents. Hep C antibodies, because they're extreme. Hep C, of course, is very prevalent in the population that we would be considering Suboxone and Subutex. And then finally, hepatitis B, also very common in this population. So when we think about induction, of course, one of the things that we are strongly trying to avoid is precipitated withdrawal. And the way that we do that is to make sure that a patient is actually in moderate withdrawal when we start this medicine. And so there's a particular scoring system called the COWS scoring, Clinical Opioid Withdrawal Scale. And the COWS scale takes into account a multitude of both subjective and objective measures of opioid withdrawal and combines them into a score that you can use to determine how bad the withdrawal that somebody's going through is. So things that you look for, starting from the top, tachycardia, excessive yawning, patients sweating, sort of diffuse bone and joint aches for a patient, dilated pupils, piloerection or goosebumps, GI upset, nausea, diarrhea in particular, being really restless and agitated, runny nose, tremors, and then anxiety and irritability are all components of this score. When you put it all together, you will be faced with a number, and that sort of categorizes roughly into the scores that you see here, either mild, moderate, moderately severe, or severe. And based on this, we can sort of start patients on Suboxone. So at our facility, we use Epic as an EHR. And so we are able to easily identify, the nurses can score these on a regular basis, and then it goes into our charting system. Of course, the EHR at your facility may be different, or you may have a different working of Epic, but in our particular facility, you just go down to flow sheets on the left-hand side of your screen here. And then you can find the behavioral health withdrawal scales, or BH withdrawal scales, and COWS scale is something that's listed right there. And you can see an example of one here that a nurse has filled out, and here's your total COWS score at that particular time for that patient. Once you have found this once, you can add it to your favorites so that it stays up here and is more easily accessible, and you do that using this screen here. To get things, as we call it, wrenched into your system. Whenever you induce somebody on Suboxone in the hospital, it's really important to make sure that they're going to have good follow-up because this is, as we mentioned, a lifelong medicine, and so you want to make sure that the transition from hospital to clinic into the outpatient world is smooth. If you guys are viewing this and you happen to live in Sonoma County in Santa Rosa, California, we do have several wonderful partners in the community that can help us out. Ironically here, it's a little bit more challenging to get treatment for patients who have private insurance or who are out of county. But for patients who are who have our partnership health plan, which is part of Medi-Cal or Medicaid in the state of California, or who have Medicare, there are several community health centers who are actively prescribing Subutex, including Petaluma Health Center, Sonoma Valley Community Health Center, Santa Rosa Community Health Center, and then also West County Health Centers are actively prescribing as well. There's also another agency that's not listed on this, which is the Drug Abuse Alternative Center, or DAC, in Santa Rosa, which has just started their own Suboxone program in addition to their methadone treatment program. And then for patients who do have private insurance or are out of county, there's a really fabulous resource that you guys also have access to, which is called Bright Heart Health. Bright Heart Health is a telemedicine service that allows people to go to meet with a clinician remotely across just a cell phone that has an app available to it, and have their counseling sessions and then eventually get their prescriptions administered by that clinician. So for patients who live a little farther or in rural areas, this has been a great resource for us. The other thing to know about is that SAMHSA does maintain a list of current active Suboxone prescribers on their website. These are people who are ex-waivered only, the special training that you need in order to prescribe Suboxone outpatient. It does not tell us whether they actually incorporate that into their practice, but it can at least be a starting point for you and patients to find the correct follow-up for them. Now, induction is a little tricky because you're dealing with patients who have an addiction and a dependence. You are having to put them into mild to moderate withdrawal, and that's not a great experience for the patient. It can be extremely uncomfortable, and with patients who can tend to be a little bit more volatile, it can lead to patients leaving against medical advice and things like that. And just in the consideration of general humanity, it's really important to make sure that you're keeping patients as comfortable as possible during the induction process. And so there are some adjunctive medicines that you guys can consider when you're going through this process to help patients with symptoms. For patients who are having pain, of course, you have Tylenol that you can do on a regular basis to help them feel a little bit more comfortable. Medications to manage anxiety for these patients include clonidine and diphenhydramine. And for GI upset, obviously Zofran is an option for nausea, and then loperamide for diarrhea that patients may experience. And then consider medicines like trazodone and melatonin while you guys are inducing patients. These medication dosages are suggested by the SHOUT protocol, which you guys can also take a look at online. So then, while we're thinking about keeping patients comfortable, we also have to figure out exactly when to start the induction. And so the COWS scoring is what helps us to do that. And I'm sharing with you guys the protocol that we use at our facility, which again is another SHOUT, S-H-O-U-T, protocol. So the first thing that you do, of course, is you stop all opioids that the patient may be on. And you're going to check your COWS score at that time. It's hopefully not going to be too far into the withdrawal range if you just start medications. And then you are going to, assuming the patient's not in withdrawal at that time, you rescore every 2 hours until the patient hits a score of 8 or greater. And that's when they're considered in mild to moderate withdrawal, and it would be safe at that time to administer Suboxone. So once the patient hits 8, you administer a dose of 4 milligrams of buprenorphine. And after that first dose, you reassess in 1 hour with another COWS score. And then based on that, you either administer another dose of 4 milligrams right at that 1 hour mark, or you can go out to a 6-hour scoring. And from there, throughout the entire first day, you're going to score every 6 hours to see if the patient needs additional medicine. The typical total dose on day 1 is a maximum of 16 milligrams, although some patients may find that they're comfortable under that amount. You take that total dose that you get on the first day and you use it as your starting dose for day 2. And then you go back and you can reassess throughout day 2 to see if they need additional medicine. Again, typical doses going up as high as 24 milligrams. There is a wonderful resource for us folks in Northern California, which is the UCSF Warm Line. It does have limited hours that are sort of in line with business hours. The number is listed there on the screen. These are experts in addiction and Suboxone in particular who can answer questions that come up through this process. So I encourage you guys to reach out to them if you're struggling with a particular issue. When we're talking about our patients at our hospital who get discharged, we have decided that patients should need to have a follow-up within 3 days. And so we have a very close working relationship with those community partners to make sure that they have good continuity of care at that time. The buprenorphine prescriber who writes the script upon hospital discharge must be ex-licensed. And then make sure that you discharge these patients with naloxone as an overdose prevention agent should something not go according to the plan. And then for these patients, also consider, given the high comorbidity rates in this population, consider PrEP for HIV prophylaxis. So what happens, we've sort of gotten the patient induced on Suboxone, and now we're talking about maintenance of the patient. What does maintenance of Suboxone look like in terms of the effect that it can have on a patient's life? So we find in studies that patients on Suboxone have higher rates of retention in treatment, and there's actually a dose-responsive effect with this. So for low-dose buprenorphine, which is pretty uncommon, 2 to 6 milligrams, about 1 in 4 will be retained, or 25%. Not bad, but when you look at higher doses, for medium-dose buprenorphine, you get about 1 in 3 retained in treatment, and then for higher dose buprenorphine, even as high as 1 in 2 retained in treatment over prolonged time. We do see reductions in illicit opioid use as determined by drug screens at the time of prescribing, reductions in mortality from opioid overdose deaths, reductions in criminal activity, and also in high-risk behaviors such as high-risk sexual behaviors in this population. We also do see a reduction in healthcare costs over time when these patients are treated, and of course, an increased quality of life as people are not struggling with the elements of an active addiction. And this is a great time to talk about why it's important to be considering buprenorphine as a maintenance therapy. The truth of the matter is that when patients are maintained on this for a short amount of time and then tapered off the medicine, relapse to opioid use is high. And so this was a wonderful study in which patients were either continued on buprenorphine for 3 weeks and then tapered off the medicine, or continued it on it over the longer term. And this graph gives a sense of retention and treatment over 14 weeks in this study. And so you can see that patients who were tapered in the blue line, after their medication was stopped, there was a pretty stark and consistent drop-off in treatment rates for these patients, so people coming back to treatment. But for patients who are maintained on the therapy, there was actually a promising or longer period that they stayed in treatment, as indicated by the orange line. So when you are working with these patients in an outpatient setting, you want to make sure that you're establishing what the goals of treatment are for them, and making sure you're setting up expectations for why you would choose to discontinue the medication, and particularly looking at illicit use or concerns for diversion, discussing with them that you would be checking a opioid prescribing database to make sure that there's not red flags in that. For most of these patients, they're going to start out with weekly visits, and depending on your clinic and your availability, group therapy, individual therapy, those types of services. And then for stable patients, they may space out to as distant as monthly visits to get their Suboxone scripts. And then it's really important to keep up with toxicology screenings for this population, both to inform your prescribing practices and also to give these patients a set of responsibility to adhere to.
So we talked a lot about Suboxone, and this talk really focused on Suboxone, but to complete it, we wanted to talk about other options available as well. And so I like this particular quote here that says that in reference to medication-assisted addiction treatment, all treatments work for some patients, but no one treatment works for all patients. And so what are some of our alternatives? Well, when we talk about treatment of opioid substance use disorder, we have another opioid agonist therapy besides buprenorphine, and that's methadone. Methadone is different. It is only prescribed by dedicated outpatient clinics, and so it's not something that we do in the hospital at the moment. However, there is opioid antagonist therapy with naltrexone. And recent papers have shown that naltrexone treatment can be as effective as Suboxone. But there are some more difficulties with naltrexone. Patients typically need to come off of all opioids for at least 7 days, maybe even 10. And so that makes it difficult to bridge onto naltrexone, whereas most patients maybe can come off their opioids for 1 or 2 days and then reach an appropriate COWS level score to go on Suboxone. This can be difficult. But if you can get them there, this could be an excellent consideration. Naltrexone is in both tablet and IM depot form. Usually in the outpatient setting, we start with tablets to make sure someone's okay. And then once they're stable on tablets, then they can come in for monthly depot injections. And this can be very convenient. There's also certain individuals that might do better on naltrexone for a myriad of reasons. Maybe law enforcement officers or pilots or individuals of this nature, to where maybe them being on Suboxone or methadone is not an option for them. And then broadly speaking, when anyone's on this treatment, psychosocial treatments generally improve outcomes. Psychosocial treatments in and of themselves without medication-assisted treatment shows very high rates of relapse. And so here I'm not talking about psychosocial treatments in and of themselves. I'm talking as in addition to medication-assisted treatment. And then there's the saying of drug-free, medication-free recovery. And this really does have an ambiguous meaning in terms of abstinence-based recovery. Unfortunately, right now, this is showing very high rates of relapse, and that's why we're really moving towards medication-assisted treatment and perhaps, again, psychosocial treatments as support with that. And here's our references, particularly for my slides. I took a lot of information from the ASAM 2018 review course, and I just wanted to mention that. Thank you for your attention.